Navina, we can start.
Okay. Good evening, everyone. Welcome to the HICS webinar, the Journal Club. Today we'll be discussing about the Mercy trial. Dr. Khadir Khan is our speaker today. Dr. Ghanshyam sir will take over for the introduction.
Good evening, everybody, and we welcome you all to the HICS Journal Club. We had started the Journal Club some time back, and because of certain logistic issues, we had kind of given a break, but we are back again. And it's my proud privilege to introduce Dr. Jose Chaco, who has been a teacher to both me and Dr. Srinivas. Both of us were trained under him, and he's one of the most well-read intensive care specialists across the country. Dr. Jose also writes a critical care blog, which has been featured as one of the top 10 blogs in intensive care in the world. Welcome, sir. Sir has agreed to be the mentor for our journal clubs. It's really our luck and privilege that sir has agreed to be the mentor.
Welcome, sir. Thank you very much. It's my pleasure to be here.
Yeah. So we thought we'll discuss the Mercy trial, which was recently published. A very, very pertinent subject to our day-to-day life. With that brief introduction, I'll hand it over to Dr. Kadir.
Good evening, sir. It's been a great pleasure and honor to speak in front of eminent speakers like sir and Ghanshyam sir. Ghanshyam sir is my teacher and I have been trained under him. And he has given me this opportunity to speak about the Mercy trial. To start with, the Mercy trial was published in June 2000. One second, let me share the screen. Yeah. So Mercy trial was published in June 2016 in JAMA. June 16th in 2023 in JAMA. It was the principal authors are Giacomo Monti, Nicola Bradic, Matteo Mazzaroli, and et al. It was the outline of the trial we will be discussing in these headlines. One second. Introduction of the trial. What is the study design? Outcomes of the study. How was it compared with other studies and how our previous studies helped in making this trial? Limitations of this trial and conclusions and the viewpoint of the authors. So what is Mercy trial? It is continuous versus intermittent meropenem administration in critically ill patients with sepsis. And why do we need to do this study despite other studies being present? To date, there was no suitably powered double-blinded randomized controlled trial focused on meropenem have been conducted in critically ill patients with sepsis to test this hypothesis. We know as per the pyramid of evidence, the RCT comes on the third list, first being the systematic reviews, meta-analysis, then the RCTs. So being a well-conducted RCT will help us in guiding the study, which we are going to know whether it is helpful, whether it will be appropriate or in clinical scenarios, whether we'll be able to use it or not. So RCT means it's a good conducted study, and we'll see at the end how these results will be helpful in our day-to-day clinical practice in our ICUs. What was the design of the study? It was a multi-centered, double-blinded, randomized controlled trial with 1:1 allocation at 31 intensive care units of 26 hospitals in 4 different countries, Croatia, Italy, Kazakhstan, and Russia. Patients were aged between 18 years or older, admitted to the ICUs, requiring antibiotic treatment, mostly with meropenem by clinician's assessment, who had sepsis or septic shock. The sepsis and septic shock criteria as per the modified sepsis 3 guidelines, they have taken the definitions and allocated the patients whether they are in sepsis or septic shock, considering even systematic inflammatory response also. Few of the patients were also receiving other antibiotics before allocating to the meropenem group. Randomization of the study was done with web-based centralized randomization by the attending ICU physician. A list was prepared with the use of computer permitted block sequences. And then randomization was stratified according to the study center. All 3 patients, physicians, and study investigators are blinded to the treatment allocation. So nobody knows who were enrolled in the controlled continuous infusion of the meropenem or an intermittent infusion of meropenem. Because even if the patient was receiving as an intermittent dose, they were being run by giving a syringe pump filled with saline to avoid bias. So they included 289 patients were excluded of the 697. Total of 896 adults were included. Of this, 289 were excluded. 196 met the exclusion criteria, and 107 already received meropenem or other carbapenem antibiotics. 81 had little chance of survival based on the SAP score of more than 65, and 8 patients who were taking immunosuppressants were excluded, and 45 patients were excluded because of the decision of the attending physician. 77 were because of the logistical issues, and 3 of the patients died prior to the randomization, and 18 were the other reasons where they could not be included in the Mercy trial. Of the 607 randomized, 303 were randomized to receive a continuous administration of meropenem. One was crossover, he received an intermittent infusion. So out of the 303, 302 were included in continuous administration of meropenem group, and 304 patients were randomized to receive intermittent administration of meropenem. So of the 302, 279 met the protocol standards. 11, these are the flaws which we will discussing. 11 did not have blood cultures obtained before the study. So it comes in the limitations or the drawbacks of the study, which we'll be discussing in the later part. 2 of the patients had a SAP score of more than 65. 4 were unblinded. 2 were receiving immunosuppressive medications and long-term corticosteroid therapies. 1 of the patient received meropenem or other carbapenem antibiotics. The other patient had retroviral disease. So 303 were included in the primary analysis. 297 included in per protocol analysis. Per protocol is nothing but all the patients who were, as per the randomization, who were taken into the study, and the results were published. We had different type of studies. Like, I'll not be going in detail about the statistical part, intention to treat analysis, wherein the patients who were crossover or who were withdrawn will not be included in the studies. In 304 randomized patients were receiving intermittent administration of meropenem. 280 met the protocol standards. 14 did not have the blood cultures as compared to the previous. We said 11 did not have blood cultures. 2 were unblinding. 2 had short interruption of the study drug, and 3 patients received immunosuppressive or long-term corticosteroid therapies. 2 patients were already receiving meropenem or carbapenem antibiotics, and 1 patient had allergy or intolerance to the drug. How were the intervention done in between these 2 groups? After the collection of the microbiological specimens, patients were microbiological specimens. Any patients who were suspected to have infection, blood cultures were obtained. Suspected site of infection of cultures were also obtained, and patients were randomized to receive either a continuous administration of meropenem as a dose of 3 grams over 24 hours, or an intermittent administration over 30 to 60 minutes of an equal dose that was divided into 3 daily boluses of 1 gram every 8 hours. To maintain the blinding, each patient experienced both types, as I discussed, to maintain the blinding and to avoid bias. Even if the patient who were in the intermittent administration of meropenem was blinded using a double dummy technique according to a randomization group assignment, in which they were given through an infusion pump, placebo, 0.9% of solution of sodium chloride. Dose was adjusted based on the creatinine clearance. It was reduced to 2 grams per day if the creatinine clearance was less than 50 ml per minute per 1.73 meters square. In special circumstances like patients having meningitis or patients having high MIC, patients who are with high MICs, the dose of the meropenem was doubled. The study assessment lasted up to 28 days after the administration of the first bolus of the study drug. Duration and its interruption were according to the clinical judgment. What were the parameters which were considered during the study? Vital signs, history of previously administered antibiotics were also taken into consideration. SAP score, SOFA score, Glasgow Coma scale, mechanical ventilation status and the settings, urine output, and the site of infection the patient had. Results were recorded between the in between a duration of 4 years. from 5th June 2018 to August 9, 2022, 607 patients were randomized. 303 who received meropenem by continuous administration, and 304 who received meropenem by intermittent administration. The primary outcome was a composite of all-cause mortality and emergence of pan-drug resistant or extensively drug-resistant bacteria. We know the definitions: pan-drug resistant, what does it mean? And extensively drug-resistant bacteria. And the pre-specified secondary outcomes included were days alive and free from antibiotics at day 28, days alive and free from ICU at day 28, and all-cause mortality at day 90, and cumulative SOFA score at day 28. Statistical analysis: the composite primary outcome was analyzed using a two-tailed chi-square test based on the intention to treat analysis. Data were also analyzed using per protocol analysis based on the modified intention to treat principle in patients with multi-drug resistant bacteria but sensitive to meropenem. Data were stored electronically and analyzed using a Stata software version 16. A two-sided p-value less than 0.05 was considered as statistically significant threshold. These were the primary outcomes compared between the two groups. We can see of the total patients who were enrolled between the 303 in continuous administration and 304 in the intermittent administration group. Components of the primary outcome: composite all-cause mortality was 142, 47% in the 303 group, and 149, 49% in the intermittent administration group. So we can see the difference is not much. Components of the primary outcome: all-cause mortality at day 28 was 91 and 99 in intermittent group. Emergence of pan-drug resistant or extremely drug-resistant organisms was 24% and 25% in intermittent administration group. Secondary outcome, as I said, 90-day mortality was 127. That is comes up to 42%, which is almost the same in both the groups. And patients were alive and free from antibiotic at day 28 were 3, and 2 were in the intermittent administration group. Alive and free from the intensive care unit at day 28, both groups it was 0. Length of our intensive care unit, post hoc analysis, they found length of intensive care unit stay 11, mean of 11 days. Length of intensive care unit and unit stay among those who survived to 28 days or 12 days, which is almost the same. Length of total hospital stay was 21 odd days. It was 22 in the intermittent group. The length of hospital stay among those who survived to 28 days, median interquartile range was 26 in the continuous group and 30 in the intermittent administration of meropenem group. Readmission to intensive care unit, 13% in the continuous administration group and 9% in the intermittent administration group. So of all the 607 patients who were studied, the mean age of the patient was 64, the standard deviation of 15 years. 203 were women, 33%, including the measurement of the 28-day primary outcome, and completed the 90-day mortality follow-up. The majority of the 369 patients, 61%, had septic shock. The median time from hospital to randomization was 9 days, and the median duration of meropenem therapy was 11 days. Only one crossover event was recorded, as I told you earlier. The primary outcome occurred in 142 patients, 47% in the continuous group, 149 patients in the intermittent administration of the meropenem group. Of the 4 secondary outcomes, as we discussed in the table, none was statistically significant and no adverse event. The other point was also mentioning the adverse event which occurred with the use of meropenem that related to it. There were no adverse events like seizures or any allergic reactions. At 90 days, mortality was 42% both in continuous group and in the intermittent administration group, so which is almost the same. These were the baseline characteristics of the patients. As I told, mean age group was 65, female to male ratio almost like 36% and 31% in the continuous intermittent administration group. 64% were males, 69 were in the intermittent administration group in males. Race, ethnicity, and all, which were almost matching the statistics of both the groups. What were the limitations of this study? The only problem was the clinician could be able to change the dose of meropenem throughout the study period by reducing or doubling it based on the kidney function or the clinical decision of the patient's characteristic of his infection and the source of infection. If the patient was having meningitis and patient with high MIC, they were given a doubling dose of the meropenem. This study also focused only one molecule, meropenem. Meropenem exerts, we know that the exertion of meropenem is by bactericidal action, and the post-antibiotic effect is also associated with the delayed growth of bacteria following exposure. And that can be, the post-antibiotic effect can be seen with meropenem group that have been useful in treating strains like E. coli, Klebsiella, Pseudomonas, and it ranged from 0.7 hours to 2.4 hours and may have contributed to the study findings. Therefore, the observation of this study cannot be extrapolated to other beta-lactam antibiotics because meropenem also have a post-antibiotic effect. In this one study, we could not do a therapeutic monitoring of meropenem dosing. So again, this study, because at the starting of trial, no clear recommendation has been issued to monitor the therapeutic drug levels of the meropenem. The patients also have received concurrent therapy with other antimicrobials. So again, we don't know in which group they have received previous antibiotics other than meropenem. The other drawback is the study was underpowered to detect a smaller treatment effect than expected. One more thing, it was that. And few did not collect the detailed data about microbiological cure of the baseline infection after randomization because it does not always reflect the clinical cure, but presented the data about the clearance of the primary infection because we were not able to collect the primary microbiological, whether the infection is cured or not. Comparison to the other studies, previously all other studies showed that continuous administration or extended administration of beta-lactam antibiotics, because the PK/PD of beta-lactam antibiotics is the time more, if it's more than the MIC, then the exertion of the effect of these beta-lactam antibiotics will be better, would be superior to intermittent administration. Several meta-analyses found reduced mortality or increased clinical cure in patients receiving continuous or extended duration of administration of beta-lactam antibiotics. However, RCTs have reported inconsistent findings, and the same in this our RCT also shows this inconsistent findings. The previous pharmacological studies supported that the continuous or prolonged administration of meropenem with higher plasma and subcutaneous concentrations for resistant pathogens, the delivery of greater exposure to target the minimal inhibitory concentration is useful. In addition, the expert opinions also suggested that continuous administration of beta-lactam antibiotics, highlighting the pharmacokinetic and the pharmacodynamic advantage of continuous infusion, the feasibility of the technique, and likely maximal benefit in critically ill infected patients by resistant organisms. That is more important. The comprehensive subgroup analysis is also performed in populations that theoretically might have greater benefit from continuous administration due to the PK/PD, as I told. These patient characteristics might explain the different findings between the current study and the previous randomized evidence. Unlike previous studies enrolling patients in the very early stages of sepsis, most patients in the current study experience hospital onset sepsis, which often results in a poor prognosis with a limited modifiable clinical course. So the limitation is again in the randomization, we don't know which group, whether the continuous group has received a sickest of the patients or the intermittent group have received a patients who are not into septic shock. So these were the things where was the outlier wherein we could not be able to differentiate. That might be affecting our results, which is almost the same in continuous and intermittent administration group. This is the Kaplan-Meier analysis for the primary outcome and secondary outcomes of probability at day 20, probability of mortality at day 28. You can see in the first graph, composite primary outcome. The composite primary outcome was the emergence of the pan-drug resistant organisms and also the mortality at day 28, which shows almost like the intermittent administration group is the yellow one and the blue one is the continuous administration group. So we could not find statistically much difference between these two groups. Same with the probability at day 28 mortality. See, if we see at the graph, these two does not show much difference between the continuous administration and the intermittent administration group. So what do we conclude from the study which we have done by these four ICUs by Giacomo Monti and Nicola Bradic? In critically ill patient with sepsis compared with intermittent administration, the continuous administration of meropenem did not improve the composite outcome of mortality and emergence of pan-drug or extensively drug-resistant bacteria at day 28. So what will be the take-home message? As we have discussed from the previous studies and from the pharmacokinetic profile of the drugs, high likely benefit of continuous administration of beta-lactam antibiotics because of the PK/PD profile in critically ill patients having resistant organisms. What will be the target for our future RCTs? Should be like subgroup of patients who could benefit from continuous administration of meropenem. As I said already in starting of my talk, that systematic reviews and meta-analysis comes on the top of the pyramid of evidences. So we need more of the RCTs to be included in this meta-analysis or systematic reviews to know whether continuous administration of meropenem is better versus intermittent administration of meropenem. Thank you, sir.
Thank you, Dr. Khadir. I request Dr. Jose to tell his comments on this Mercy trial.
Thank you very much, Dr. Khadir, for the presentation. It's a very pertinent question that we face every day in our ICUs as to whether to give beta-lactams as a continuous infusion or as intermittent doses. And this question has been actually going on for a fairly long time. I remember even during our days at Manipal, more than a decade ago, we had switched to continuous infusions in preference to intermittent dosing with most of the beta-lactams. So this is based, as we heard, based largely on the pharmacokinetic properties of beta-lactams, the efficacy of which lies on the time above the minimal inhibitory concentration. So once you attain a level of about 4 to 5 times the MIC, increasing the level further does not improve the bactericidal effect with beta-lactams. So you just need to maintain that level. On the other hand, if you give an intermittent dose, you get peaks and valleys in the levels, and that actually, during the periods of time when the level is actually low, it has the potential to result in the emergence of resistant bacteria. So that's the reason why, both in terms of its bactericidal effect, as well as in terms of reducing resistant organisms, a continuous infusion may be preferable. And previous studies, there were 2 meta-analyses which showed improved survival. Of course, the survival and the time point of survival was different in different studies. But both these meta-analyses showed that there is improved survival if you administer beta-lactams, not meropenem specifically, beta-lactams as a continuous infusion. And with meropenem, there is one previous randomized controlled trial from the Czech Republic that was published again about more than 10 years ago, where they compared continuous infusion versus intermittent administration. And they found that although they didn't look at mortality, they looked only at clinical and bacteriological cure as their main outcomes. As the primary outcomes, they looked at mortality as well. They found that microbiological cure was superior with continuous infusions, although the clinical cure rates, according to their definition, was not different between continuous infusion or intermittent dosing. And they also found some subtle difference, some subtle advantages with the use of continuous infusion in terms of a shorter ICU stay, shorter duration of ventilation, etc. So it was based on these available data that the authors of the Mercy trial embarked upon this particular trial, in which they looked at intermittent dosing versus continuous infusion, specifically of meropenem. And as we saw, they could not find any difference in the primary outcome. The primary outcome was a composite of 28-day mortality and the emergence of pan-drug or extensively resistant bacteria. So this composite outcome was similar in both the groups. Where is the composite primary outcome? Then they looked at some secondary outcomes as well. They looked at the individual components of the primary outcome, namely the 28-day mortality, as well as the incidence of resistant bacteria as in pan-drug resistant and extensively drug resistant. So these individual components were also similar. There was no significant difference. Secondary outcomes, including 90-day mortality, days alive and ventilator-free at 28 days, were also similar. So essentially, this study failed to show any discernible clinical advantage with the use of with a continuous infusion compared to intermittent dosing of meropenem. There were several points which add to the strength of the study. As the authors themselves report, this is the largest RCT that has specifically looked at meropenem infusions versus intermittent dosing. The study was double-blinded, so neither the investigators nor the evaluators knew exactly which group the patient belonged to. The patients chosen were based on standard definitions of sepsis and septic shock, in whom the question is most relevant and applies to ICU patients as well. And they used a fairly standardized protocol of management based on the surviving sepsis guidelines and also based on local protocols. All that is fine. Very well executed study, something that's of great relevance to ICU practitioners, of course. But as we heard, there are a few moot points which I would like to highlight. First and foremost is the outcome itself. They looked at a composite primary outcome. Now, there are several problems with composite primary outcomes in that there may be no discernible relation between one outcome and the other. In this case, the 28-day mortality and the emergence of resistant strains. You may ask the question, does it really matter all that much in terms of emergence of resistant organisms if you're looking specifically at 28-day mortality? Why combine the two? Why not look at the mortality itself? Or look at, like the previous study did, look at clinical cure rate, which may be considered a more meaningful outcome, or the bacteriological cure rate, which again may be a very pertinent outcome. The problem with this composite outcome is, although they look at 28-day mortality, the study was not powered to assess 28-day mortality. For instance, if you need to look at the 28-day mortality in severe sepsis or septic shock, you need a minimum sample size of 1,500 patients. That is the sample size that was followed by the PROMISE, PROCESS, and the ARISE trials. And you need such a big sample size, which obviously this study did not have. They just had close to 600 patients. That's not enough to look at mortality. So it doesn't shed light on whether mortality changes with one approach or the other. That question is not answered. It just cannot be part of a composite outcome to assess the mortality or survival itself. And then, of course, they did not look at clinical cure. They did not look at microbiological cure, which may be important and was what the previous RCT specifically looked at. Then, of course, a large number of patients, in fact, when I looked at the numbers, close to 67% of patients were on antibiotic therapy in the 3 months preceding the study, yes, which could have resulted in some alteration of the microbial flora and could have led to the emergence of resistant organisms. Quite possibly, it is plausible that this may have happened. We don't have information regarding what sort of concomitant antibiotic therapy that they use. That's one of the problems with using drug resistance as outcome, because we don't know what they were using. They may have been using a whole plethora of different types of antibiotics of different spectra, and that may have influenced the resistance pattern, which we are unaware of. We do not know. Then the median time from hospitalization to randomization was about 8 to 9 days. Time from ICU admission to randomization was 5 days. And during this period, that's the delay in administration of meropenem. But during this waiting period, as I mentioned, other antibiotics were administered, obviously, and that could have possibly biased the results, particularly in terms of emergence of resistant bacteria. Then, of course, if you look at the duration of treatment, the median duration overall was 11 days, and the median duration among 28-day survivors was 13 days. You might argue that this is perhaps a little too long. There are many studies which suggest that 7 to 10 days is all you need in most infections, one. And secondly, if you source control early, particularly in patients with surgical foci, it might actually be beneficial to cut down the duration of therapy even to shorter periods of time. We do not know, others do not provide details about the surgical cases, what kind of surgical cases they were, and how many patients at source control, we do not know. So overall, if you look at it, the duration of treatment may be a little too long, and that in fact may lead to the emergence of resistant organisms as well. And they did not use any preset criteria for cessation of antibiotic therapy, which I feel you should do in a study like this. It should not be left entirely to clinician judgment. We see every day patients languishing on antibiotic treatment for days together, weeks together, and that may well have happened in this case as well. And the physician could adjust the dose based on renal function or based on their own judgment, which again may have resulted in bias. There were guidelines provided, but they were just recommendations, and the final judgment regarding dose adjustment was left to the clinician. The next question is, would this apply to higher doses of meropenem? Like some patients we know who have a high MIC, you may use a dose of 6 grams per day as against the usually used dose of 3 grams per day. And would the results be extrapolatable to high doses as well? Patients who are immunosuppressed were not included. They were specifically excluded. Again, you might argue that this may precisely be a subgroup of patients in whom continuous infusion may be more beneficial compared with intermittent dosing. And of course, as we heard, the results of this study is only specific to meropenem. It cannot be extrapolated to other beta-lactam antibiotics. So at the end of the day, we use continuous infusions all the time with beta-lactams. And to me, there are two fairly strong meta-analyses that suggest improved survival. And there is one randomized controlled trial which supports clinical and bacteriological cure. And even in this study, if anything, continuous infusions are equally effective, by no means inferior, compared to intermittent dosing. And it is far more convenient to run a continuous infusion rather than 8-hourly opening ampules, mixing, loading, injecting, etc. So to me, continuous infusion makes good rationale based on pharmacokinetics, as well as efficacy, convenience, and there is pretty good evidence that supports that it may improve clinical outcomes as well. And if you add this study to the already available meta-analysis, of course, you will come up with the finding that the findings of the previous meta-analysis still holds true, and you will surely find that survival is better with continuous infusions. So that's my take. What do others think?
So what is your practice, and will this trial change your practice, and why?
As I mentioned, our practice has been, even from more than 10 years ago, we've been using mostly continuous infusions with beta-lactams, and that practice would continue regardless of this, the findings of this paper, largely because continuous infusions are at least equally effective. by no means inferior. And there is some subtle data that suggests that it may be superior in terms of clinical outcomes from previous meta-analysis and one randomized controlled trial previously. So that's good enough for me. I will continue my practice. I will not change.
Ghanshyam sir, what is your practice and did this trial change your practice?
Yeah, just a couple of comments about the trial. So what do you think about a good number of patients actually had gram-positive infections in this trial? In fact, a good number of patients isolated cons. Many a times, we assume that cons could be a colonizer and could actually kind of hint that the collection of the sample may not be appropriate. Like almost about 116, if I'm not wrong, patients had a coagulase negative Staphylococcus aureus was isolated.
Yes, of course. You would.
And meropenem traditionally we don't actually give for
Gram-positive.
Yeah, you don't use, that's true. But if you begin empirical treatment and later you grow something that is sensitive, you perhaps would continue. And in this particular study, I don't know, they don't mention about de-escalation of treatment or switch based on availability of cultures and so on. We only know about the median duration of treatment, 11 days overall and 13 days in 28-day survivors. So all those are pertinent questions, but as I mentioned, in the real world, this kind of questions would arise. So that's a problem with randomized controlled trials as well. You cannot control everything.
What about the cost burden on the patients, sir?
Navina, we as I said before, we were trained under Dr. Jose, and I remember back then, from 2006, when I did my fellowship, we were using continuous infusion of antibiotics. Though the duration probably was not for 24 hours, but we were using, we never gave boluses. It was through a syringe pump, infused over a few hours, and we have been continuing that. And so I really don't think that's going to change based on this study. I think we're going to continue
cost burden of the
infusion.
patients. Using an infusion pump. If you look at the cost of using infusion pump for the patients, does it add to the cost burden to the patient? Should we look at that one, or should we look at
the way it is charged per day infusion pump. So whether you use the infusion pump 3 times a day or continuously, I think it won't make any difference.
Yes. But if the patient is already having 3 infusion pumps of noradrenaline, vasopressin, and a hydrocot infusion is going on, and above that we add in one more infusion pump for an antibiotic. So in a corporate, how the cost will be, like for each infusion pump per day to be 1,000 charged. So should we add, if you look at the cumulative effect, will this cost add to the patient benefit of the outcome, or will increase? So in that way, if you look at it, how does it benefit? By reducing the length of the hospital, because the primary composite outcome, what they said was the 28-day mortality was reduced. So in terms of the mortality, if you see, the patient is getting better even if you add cost to it. But all the ICUs in Indian setups and all, that would not be practically feasible to use syringe pumps, infusion pumps for antibiotics also, sir. What do you say on that?
I think I'm not sure about other hospitals, but wherever I have worked, we haven't charged specifically for the number of infusion pumps that were running. One. And second, of course, even if it adds a little bit to the cost, I think it would still make rational sense. At least some of the studies have shown that the duration of treatment could be cut down if you use a continuous infusion as against intermittent dosing. In fact, that was a finding from the previous RCT that I mentioned. Yes. So you should consider that as well, even if it doesn't translate into improved clinical outcomes. And of course, the ventilation days, ICU days, etc., were noted to be lower with continuous infusions in the previous study. So when you take all these things into account, although we don't have data to support that, it would make, I think, rational sense to still run it as an infusion rather than use intermittent bolus. And of course, and even if it's a intermittent bolus dosing, as Ghanshyam mentioned, you would normally give it over a period of at least 30 minutes to 1 hour. And you would generally tend to use an infusion pump in that situation rather than run it freely. So that may not really make much difference. One of the problems is the availability of lumens. If you use triple lumen catheters and if you run too many infusions, to add an antibiotic to this whole milieu may be at times may be difficult. So that may be a consideration.
So in these kind of studies where we compare the continuous versus intermittent boluses studies, instead of mortality, do you think the results would be better if we do other outcomes like time to stabilization or shock reversal? Or are there any other outcomes that we can measure for the antibiotics especially?
Yes, that's what I mentioned previously as well. If you are looking at mortality in patients with severe sepsis septic shock, and if you need to power it adequately, you need 1,500 patients. Not easy to do. In fact, all the previous studies which were conducted in patient septic shock, like the PROCESS, the PROMISE, and the ARISE trials, they had 1,500 plus patients. This study had only 600. So this is considered to be the largest RCT which has done this comparison. So they were simply not powered to look at survival. And in that particular case, rather than look at composite outcomes, it definitely would have been, I feel, more meaningful to look at clinical cure rates and bacteriological cure rates, which would make more sense. And it would make the study, we offer the study enough power to look at these outcomes, rather than look at composite outcomes, which is always a little bit dodgy. And the survival, of course, not at all power to look at that.
Does this affect renal function, sir? Continuous or intermittent boluses?
That is a difficult question to answer, whether it specifically matters. But there is at least pharmacokinetic data that suggests what's called augmented renal clearance in patients with severe sepsis, and also in other subgroups of ICU patients, including trauma, SIRS response, and all that. You have augmented clearance on the one hand, and that might actually be an indication to use continuous infusions. And second, of course, in patients with impaired renal function, would it have any specific advantages? Not answerable at this time because we don't have any data particularly. But as I mentioned, in patients with augmented renal clearance, as in severe sepsis, at least there is a sound pharmacokinetic basis for continuous administration.
Okay.
I think the type of RRT would also matter, whether you're going to just go with SLID or SCRRT. Probably even that would probably play a role in the way you're going to dose the antibiotic.
Yes, it probably would.
Some of them usually practice giving antibiotic post the RRT sessions, right? So if that is the case and patient is on SLID, will you still continue continuous infusion of meropenem?
I'm not sure what would be appropriate in that situation. I don't think anybody would know definitely. It'll be hard to answer that, particularly in terms of SLED treatment that runs for, say, 6 to 8 hours. And what impact does it have on the renal clearance, on the clearance by dialysis of meropenem administered as continuous infusion versus intermittent bolus dosing? That is something that may be worth studying. In fact, there is not much information on the pharmacokinetic profile of antibiotics during renal replacement therapies in ICU. That's one of the lacunae in research.
Kadir, anything else? So before we come to a conclusion, so any broad guidelines that you want to suggest to the readers or to the listeners? When we are looking at interventional studies, or when you're looking at a paper, what are the broad areas that we should be actually looking at? Because if you just look at only the conclusions, probably you may be misguided. And
Yes.
most of us have the habit of just looking at the conclusion and then trying to come to some changes in the way we practice.
Yes. Yeah, don't just read the bottom line. Look at the whole study. Of course, it will take time to analyze a paper. First and most important is the setting of the study. Does it apply to your practice? Specifically for us, critically ill patients in ICU. So does the patient population belong to that subgroup? Second would be the design of the study. Would the design of the study be appropriate to answer the question that the authors have raised? So a randomized controlled trial obviously would be the answer most of the time, but then you cannot do randomized controlled trials on every single topic under the sun. For instance, duration or the delay in antibiotic therapy after the onset of septic shock. You cannot compare early therapy versus late therapy. That will be unethical and will not be approved by anybody. So there are many such instances wherein you cannot do a proper randomized controlled trial. But then, as I mentioned, you should look at the design, and compared to observational studies without control, it'll always be better or more robust evidence comes from studies which have a control group. So that is most important, control group. Then you should look at the inclusion criteria, exclusion criteria, specifically in relation to your own practice. Did the authors exclude patients whom you think might have benefited with the intervention specifically? That needs to be particularly looked at. Then, of course, how did they screen their patients? How many patients did they include? Were all the patients followed up? Were there any dropouts? How many dropouts were there? That's very important, because if you look at many of the studies, if you look at, say, mortality, for instance, you may see 50 patients died in one group while 60 died in the other group. It may be statistically significant. But if you look at it at depth, you will find that if this equation changes to 59 instead of 60 and 51 instead of 50, the significance may vanish. That's called fragility index. So normally the fragility index for an ICU study is roughly 5 to 5 or so. Even if 5 patients change from one arm to the other in terms of outcomes, it wouldn't make a difference. So that's something you need to look at, not just the p-value. Does it really come to a robust conclusion in terms of the fragility index as well? So you cannot just go by what the authors themselves say. It always pays to do a little bit of analysis yourself and see whether changing the outcomes on a few patients would really make the conclusion non-significant. That's one. So, and of course, follow-up is very important in this regard, because even if there are a few dropouts, they might have made a difference. The dropouts who were not followed up till the end may have turned the tables from one conclusion to the opposite conclusion. So that is something you need to look at as well. Then, most importantly, are the outcomes relevant to the particular question that is being asked? Of course, we all look at meaningful clinical outcomes, among which survival is most important. We look at ICU length of stay, hospital length of stay, which are all associated with the immediate clinical outcome. And not only the short-term outcome, it is most pertinent to look at longer-term outcomes. That's what people concentrate on these days, like the 60-day, 90-day outcome, and the quality of life as well, post-ICU, which also matters. So were the outcomes that the authors looked at pertinent, relevant, and were they really the outcomes? In this particular study, for instance, 28-day mortality is a good outcome, of course, but then not adequately powered to look at that outcome. Then, of course, every study will have its own set of limitations. You should specifically look for those limitations. Do the authors discuss the limitations? It's most important that you are aware of the limitations and you specify those limitations, and you discuss as to how you try to overcome them. And most importantly, don't take the study by its face value. Just make use of the study to create a hypothesis and try to reevaluate this hypothesis in future studies. So that is also a very important pointer to look at. So this is the general way in which to critically appraise a paper. And of course, it is important in examinations as well, because most of the examinations you're asked to analyze a paper. So you should be, as students should be well versed in this respect.
Thank you, sir. Ghansham sir, what are your concluding remarks?
Kadir, do you have anything to say?
No, sir. Actually, sir have explained us everything, like how to read a paper also. Just going just by getting at the bottom line, reading and telling it as a conclusion, following up, it will be difficult. As we see in this one, underpowering of the study, as sir said, we should have a 1500 odd numbers to have a better conclusion of primary outcomes, and rather than including a composite outcome, a primary outcome looking at one point, we should consider it, because mixing two things might not be able to get a exact conclusion what we wanted from the study, as we were thinking which one is better. So at the end of study, we are not able to make out, okay, should we still continue using continuous? If we read the bottom line or conclusion, people will be like confused, why unnecessary using a continuous. We can directly start with intermittent doses also, that's almost equal and same. So explaining the other departments, specifically when intensive care is working as a multidisciplinary team, the other people can definitely ask the question, why not it is, there's no way it is beneficial, why we are using this. So this way it will become important for us to know how to analyze a paper and how to read it properly, and how we can implement those results from our those results into our clinical practice.
Yeah. So I think those at this phase, you just go by the overall or one look at the paper. It may sound that the continuous infusion may not be beneficial, but I think to go by the pure rationale on the pharmacodynamic profile or the pharmacokinetic properties of antibodies, and going by what Sir has said, that there were two strong meta-analyses suggesting a mortality benefit or outcome benefit. I think we would still continue to use most of the beta-lactams as continuous infusions in critically ill patients. And probably this study may not change that. And I think maybe there could be a few subset of patients where this may actually prove more beneficial. So with that, we will come to a conclusion of this episode of Journal Club. So thank you so much. It's always a pleasure hearing you and learning from you. And we will be back next month with a different paper, with a different set of clinical question, which will be something which we all would want to know in our day-to-day life. Thank you so much. Thank you, Joseph. Thank you, Kadir. Thank you, Navina. Thank you, everybody, for being with us. Thank you.
Thanks, Ghansham.
Thank
Thanks,
you, sir.
Kadir. Thanks, Navina.
Thank you, sir.
We'll see you next time.
Yes.
Bye.
Thank you so much. Bye, sir. Good night.
Night.